Warm welcome, Dr. Sanjana and Dr. Sanjana.
Good evening, everybody. It is a real pleasure that everybody is taking time out of their busy schedule to attend this topic. Although the dry eye management is very repetitive, it forms the basis for the foundation of every surgery. Your LASIK surgeries, cataract surgery, glaucoma surgeries. If you miss out on a subtle dryness in the patient, the results may go haywire. Hence, we have with us Dr. Sanjana Vatsa, who is a cornea refractive and cataract surgeon at the Bangalore Indira Nagar branch, to talk to us on dry eye management. Dr. Sanjana Vatsa is also the chief of refractive surgeries for the entire state of Karnataka. She's been the ex-chair for DMDA Committee of Clinical Board. She has had her fellowship from Netradama Eye Hospital along with the additional fellowship at Agarwals Eye Hospital, Chennai. Over to you, Dr. Sanjana, to walk us through the diagnosis of dry eye and its management, which holds a very key position in every day to day life.
Thank you, Dr. Sanjana, and thank you, Clinical Board and Dr. Preethi ma'am for this. And also, I would be talking on the dry eye diagnosis and management, and I'll be sharing my screen now. Very good evening to all the doctors, and today I'll be talking about the dry eye evaluation and management. So I'm going to just go a little bit of the basics to understand as to what is dryness, how it happens, and also what is the pathophysiology behind that, because the treatment also depends upon what exactly is the cause and what is the pathophysiology, and not just using the lubricants randomly, but specifically as to what kind of lubricants that we need to use and what is the next step other than the lubricants. And there are multiple things and multiple options available. So just to understand the treatment part of it, we also need to understand how the whole process or pathogenesis of dry eye happens. We say that the dry eye disease, we know it's extremely complex and it is a multifactorial disease. And it is a symptomatic disease of the tears and the ocular surface. And usually it is associated with increase in the osmolarity of the tear film. And also there is a subacute inflammatory process, which is seen on the ocular surface. Now, it is usually like a vicious cycle. So what happens usually, first, we see that there will be some tear film instability due to multiple reasons. Because of the tear film instability, there is hyperosmolarity. Basically, the tears become hyperosmolar. And because of this, it damages the epithelial cells, that is of the cornea and also the conjunctiva. Because of the damage, and there is apoptosis of these corneal and conjunctival epithelial cells. And once these cells start dying, it leads to release of a lot of inflammatory mediators. And this inflammation in turn is going to again cause a tear film instability, and the whole process just continues like a vicious cycle. Now, just let's look at how a basic eye and also the normal tear film homeostasis is maintained. Now, we see in this that the upper layer of the tear film, which is the lipid layer, is very well maintained. And below that, we have the aqueous and the mucin layer. And beneath that, we have the ocular epithelial cells, the cornea and the conjunctival cells. Now, we know that when the tear lipid layer is intact, the aqueous layer is something. So the aqueous layer is not going to escape out through this, and thereby the entire tear film is very well maintained. And also there is enough production of aqueous from the lacrimal glands, and the whole homeostasis is maintained. Now, let's see what happens if there is tear film instability. Now, we keep hearing that, there is tear film instability, the lipid layer loss. And because of this, what happens basically here is all the water content of the aqueous layer is something which starts evaporating out through these breaks. And because this evaporates, the water content from the epithelial cells of the cornea and conjunctiva starts moving towards the aqueous layer in order to maintain that osmolarity. And thereby what happens, these epithelial cells are going to lose a lot of water content and they shrink, and thereby osmolarity in these increases, and thus the normal functioning of the epithelial cells is lost, and that is how the apoptosis and the damage to the epithelial cell starts. So normally what happens when a cell starts losing water, there will be uptake of certain inorganic solutes, but these inorganic solutes are not good enough to maintain the stability and the function of these cells. Thereby, ultimately, they go in for a damage, and then thereby the apoptosis. So I said that when apoptosis happens, there will be release of a lot of inflammatory mediators. And whenever there is release of inflammatory mediators, we do see that there's a lot of T cell infiltration, matrix metalloproteinases, etc., are being released, and this starts causing further tissue destruction, and the whole cycle continues. So we do see that sometimes it can be an aqueous deficiency or it can be a lipid layer deficiency, or whatever it is, ultimately the vicious cycle of inflammation and apoptosis happens and thereby starts damaging the entire ocular surface. Now, when we look at people who are more prone to develop these dry eyes, we see that individuals who are exposed to ACs and also who wear contact lens for longer durations, or people who have hormonal imbalance, or who have got any ocular comorbidities like diabetes or arthritis, and in patients who have undergone any previous eye surgeries like refractive surgeries or sometimes cataract surgeries, or who have got any systemic medications like antihistamines and hormonal therapies, etc. So we all know the symptoms. I'm not going to go into the details of what are the common symptoms, usually in terms of dryness, blaring, irritation, grittiness, redness, and sometimes it can be reflex watering like epiphora, discharge, foreign body sensations, etc. And also people who are exposed especially to the wind and air conditioning, they do feel a lot of discomfort, which gets exacerbated during those times. And also if they have got a prolonged reading or computer use or TV watching, all the symptoms usually start getting exacerbated. Now, when we come to the diagnosis of the dry eye, so it needs to go in a sequential manner. Now, the first important thing is not just going directly to the examination of the eye. It's also important to take a detailed history. In fact, we all know about something called as the OSDI score, which is the Ocular Surface Disease Index score, and which basically asks a couple of questions to the patients, and we get a rough idea as to how severe the patient's dry eye is. Then second, also look at the face. Examination of the face is important. Then go to the slit lamp examination and look at the eyelid in detail. And then we have got the tear film examination, and finally the entire ocular surface. So when we talk about OSDI, initially it used to be a OSDI score which consists of 12 questions. Now, according to the DUCE 3, which has recently come, they have reduced it to 6 questions only. Very simple questions like asking, are you sensitive to light? Do you have blurring of vision on and off? Do you have difficulty driving at night? And while watching TV, do you have difficulties? And in windy conditions, how is it? And also in places where there is low humidity. So just by asking these kind of simple questions and getting the score, we do understand the severity of the dry eye. So this is something which is very important to start with. Second, look at the entire face, particularly in certain patients who have got like rosacea. Those people which can be clearly seen on their skin, they are the ones who will be more prone for conditions like meibomian gland dysfunction, and they're more prone to develop a dry eyes. So the next thing will be in terms of the diagnostic tests. As I mentioned, look at the eyelids, look at the tear film, and look at the overall ocular surface. Now going to a little bit of detail of each of them. Now, very importantly, in the eyelid. So we all know when we look at it, it's not just the tear film that we're seeing. You have to examine every part in terms of eyelids. How is the lid margin? Do they have blepharitis? Is there meibomitis? Is there blockage of the meibomian glands? And also, is there presence of any lid telangiectasias? And also look for lid margin keratinization, and also look for blinking. Sometimes, we do miss this. So we need to ask the patient, is there any complete blinking or incomplete blinking, lag of thalamus, which is very commonly associated with evaporation of the tears. And also you can invert the lid and see both upper and lower lid in terms of how is the gland morphology. Though if you want to know the details of it, of course, there are different tests to understand the meibomian glands in detail, but even a simple slit lamp will also roughly give us an idea as to how are the meibomian glands placed and what is the rough morphology of them. And the second thing is looking into a tear film. So when we grossly say it is tear film, we need to also understand that there are different layers in the tear film, and it's also worthwhile to understand as to which layer would be probably affected, because the treatment of it will also be according to that. Now we know there is a lipid layer, then there is an aqueous layer, and then there is a mucin layer. Now, when we look at the lipid layer, most commonly being affected, in conditions like the meibomian gland dysfunction. So when we look at the lid margin, we see that the meibomian glands may be blocked. There is capping of these glands. Not just this, also it's important to press and see what is the consistency of the meibum that is being secreted, whether it's watery consistency or whether it is in the form of a very thick paste or it is just a string like discharge. So it is important to understand so that we know the kind of treatment that we give. And second thing, if we do not, this is in the slit lamp what we commonly look at, but we also, if we have certain other investigative tools, like for example, LipidView or even IDRA, etc., they do tell us clearly exactly what is the lipid layer thickness. So even if we do not have this, a simple examination of the meibomian glands and their expressibility will give a lot of information regarding the health of the meibomian glands. And this in turn tells us about the lipid layer. Now, the second thing in terms of the aqueous layer. So when we talk about aqueous layer, commonly we see in the slit lamp, what is the tear film height? You can also use certain devices just like IDRA, which measures the tear film height as well, or a simple Schirmer's test, which we all can perform, where we all know that if the values are lesser than 5 with severe dry eye, of course, less than 10 is considered to be abnormal. So this can be done as Schirmer's 1 and 2. And then we have got the mucin, or the last layer of the tear film. Although not commonly being performed in terms of lissamine green staining, but this is very typical of the understanding of the mucus layer and also the goblet cells, which is seen on the conjunctiva. Lissamine green staining, if it is significantly seen, indicates what is the functioning and the health of the goblet cells. And also one more is the conjunctival impression cytology, not of course being commonly performed, but this again tells us the details of how is your overall conjunctival epithelial cells and the goblet cells. So this roughly gives us an idea how is your lipid layer, how is your the aqueous layer and the mucin layer. Now, the next thing is we spoke about the lids, we spoke about the tear film, and then important is the entire ocular surface. Now, it's important to look for if there is any pterygium. It might be grossly seen in certain cases like this. And second thing, in terms of conjunctival calluses, where we can see here, this we may miss out sometimes because randomly we may keep giving lubricants. The patients are just not comfortable. And if we very cleanly see that there will be conjunctival calluses, which causes a lot of irritation and discomfort for a lot of patients. And it is not going to just go away with lubricants, and it needs to be treated accordingly with conjunctival section, etc. So it's important to look at the conjunctiva and also the entire ocular surface, and also check for the sensations. Many a times it can be neurological thing where the corneal sensations might be reduced. And also stain the cornea and conjunctiva and look for how is the overall health of the ocular surface. And this in terms of if we have confocal, of course, not being commonly performed, but we need to know that under confocal microscopy, we will be able to see the corneal nerves and how is the morphology of it. And if there are presence of loss of any corneal nerves or bulbs at the end of the corneal nerves. So these things will as to what can also be the reason for dry eyes. These are, having said all these, after we examine the entire face and the eyes, when we look at what does the DUCE 3 specifically mention. So we used to follow DUCE 1 and DUCE 2 before, but now the DUCE 3, they mainly say 3 important things that has to be seen in every patient. One is the OSDI, which I mentioned already. Second, look for the tear film breakup time. This again, sometimes we may miss, we may do the Schirmer's but not tear film breakup, but this is extremely important. We may have an invasive one or a non-invasive. If we have non-invasive, better. And third, it also says stain the cornea and see how is the entire surface. Sometimes if we just look in the slit lamp, it may look still normal, but when we stain, we get a lot of information regarding the health of the ocular surface. So talking about the TBUT, we all know about it, and this is the invasive method of TBUT and non-invasive method. If we have certain equipments, like for example, IDRA, etc., that helps us in finding out the non-invasive, and it also gives a specific value as to what is the breakup time. And staining is also extremely important. Commonly, we follow the fluorescein staining for conjunctiva and cornea, and the lissamine green staining for conjunctiva. And we do see that in cases of moderate to severe dry eye, we see significant amount of staining, which can be seen on the cornea as well as on the conjunctiva. And the DUCE 3 says that if you have got more than 5 punctate spots on the cornea and about more than 9 punctate spots on the conjunctiva, along with the staining of the lid margin, this is very, very typical of the dry eye disease. So these are the common routine tests that we normally do, and most of it can be done in an OPD setup. And are these routine tests enough to diagnose dry eye? Yes, majority of the cases, these are what is mostly required to diagnose. However, if we want to extend and to even further understand what other investigations are possible, we have something called as tear film osmolarity. Now, this is a very simple, small equipment which you have to just touch the tear film, and within about 2 to 3 seconds, it gives us a value. And this talks about what is the osmolarity of the tears. And as I mentioned earlier, we know that it causes hyperosmolarity in the tears in dry eyes. So it is going to give us a value. And for our understanding, we need to know that if the value is more than 308 milliosmoles per liter, it is indicative of a hyperosmolar condition. And this is what is causing all the symptoms of dry eyes. This again, MMP9 kit, again not being routinely followed. This again is going to tell us an inflammatory marker, whether MMP9 is a very important inflammatory marker in dry eyes. So it just tells us if the value is higher, that means the inflammation in the eye is much higher. However, though we don't have these things to commonly use in our practice, but looking at ocular surface, staining the ocular surface, we do get a lot of information, and thus many a times we do know that this is inflammatory dry eye which is being involved. Other than that, if we have to look at the systemic investigation, sometimes it's not just about doing the eye examination. It's important to systemically look at the patient as well holistically. And important tests being vitamin D and vitamin B12 deficiency we need to look at, and also screen for diabetes, and importantly look for any rheumatoid or any autoimmune conditions, and even the thyroid eye disease. So this usually tells us about what are the common tests and investigations that we do to understand that yes, the patient has got dry eye, what is the severity of dry eye, and what might be the cause of dry eye. Now the next is how are we going to manage the dry eye? So when we talk about the management, again, we follow the Deuce 3 algorithm. Now, according to Deuce 3, again, they say three important things. One, you need to treat the tear film. Again, they talk about every layer of the tear film, which is the lipid and the aqueous and the mucin layer. Second, it says treat the lids. And third, the overall ocular surface. So in any patient, these are the three things that we look at: the lids, the ocular surface, and the tear film. When we talk about first is the tear film, as I mentioned, we have to address the aqueous deficient part of the dry eye. We also have to look at the lipid deficient part of the dry eye. And as we all know that ultimately it is leading to hyperosmolarity and how that can be treated. And overall, there is inflammation which is happening on the ocular surface, and how are we going to treat the inflammation? Now, when we talk about tear film, commonly the first thing that comes to our mind is yes, to start with the lubricants. Again, there are so many lubricants which can either be starting from CMC 0.5 or 1%, or whether we go for polyethylene glycol or do we go for sodium hyaluronate. There are multiple options available out there. Again, if we go into little detail, now we know what might be the cause and which layer of the tear film would be probably affected more. So based on that, we will be able to make a tailor-made approach for our patients. Now, let's say in those patients who have got meibomian gland dysfunction, and we are pretty sure that the lipid layer would be affected in them. Now, in these, of course, tear supplementation, liposomatics are important. And also, there are some important devices which will stimulate the functioning of the meibomian glands and the lacrimal glands better. Now, when we talk about the lipid deficient dry eye, commonly we start with the polymers like sodium hyaluronate, and also the addition of some drops do contain castor oil, mineral oil. So addition of that will also be beneficial. And some of the drops also do contain the lipid globules, and that also helps in restoring the lipid layer. Along with that, yes, osmoprotectant addition is always beneficial. This also improves the osmolarity of the tear film. This is commonly when we start with the lubricants, we choose these kind of lubricants. And again, going to the next step of that, we also have certain devices. So when the lubricants, and also we ask the patients to do lid hygiene, there is warm compress that they do at home. Then there is a lid massage. They massage the meibomian glands. However, in spite of all this, if there is not much of an improvement, we do have devices like, the IPL or the intense pulse light therapy, or we have the lippy flow treatment. Again, if we have to know a little bit more on this, both of them have. So there is a slightly different mechanism in which it works. Now, when we talk about the lippy flow, this is something where it is going to provide the heat as well as it will mechanically compress the glands, compress the eyelids and compress the meibomian glands. So first, with the heat, it is going to melt the meibomian secretions, which are very thick. And then with the mechanical compression, it expresses out the meibomian gland secretions. So this is how the thermal pulsation with lippy flow works. But if we look at the IPL or intense pulse light, here it's basically the xenon light, which is stimulating the parasympathetic pathway of the nerves, which goes to the meibomian glands and the lacrimal glands. And this also provides some amount of heat, which helps in melting the glands and also stimulate the glands to function better. And after this, the patient can also, massage the eyelids better, which helps in expressing out the glands secretions better. So these are something which helps in providing a better lid hygiene rather than just a home therapy of, the warm compress and the lid massage. So next, when we look at, let's say, the mucous membrane or the aqueous membrane deficiency, they do say that oral nutrition omega-3 fatty acids not only help in meibomian gland dysfunction, but also improves the lacrimal gland function and the aqueous layer. And of course, your supplementation is always there where we do have lubricating drops. Again, when we talk about lubricating drops, CMC, many people still do use CMC, and in fact, 1% works really well in terms of mild cases. Also, CMC, along with if you add cyclosporin, though it's an anti-inflammatory, it works very well in improving the mucus layer as well as the aqueous layer as well. And addition of osmoprotectants always better. And we can also combine some CMCs with sodium hyalinate, which provides very good lubrication to restore the aqueous layer. Now, lastly, if we look at the mucin layer, mostly we would sometimes go for PG combination, which works better for the mucin layer. And also cyclosporin specifically works very well for restoring the mucin layer of the tear film and improving the goblet cell function. So now we have seen that there are lubricants for different layers of the tear film. And next thing is that are we also treating the hyperosmolarity? Because we are giving the lubrication fine, but also we know that hyperosmolarity is there in the eye, which is leading to inflammation. So how important is it to treat the hyperosmolarity? Yes, very important. We might have seen in a lot of medications that there is L-carnitine, there is erythritol, there is glycerol, there is trehalose. So all these are basically the osmoprotectants, and these osmoprotectants are going to reduce the osmolarity, improve the functioning of the epithelial cells of the cornea and conjunctiva, and restores their normal function. So addition of this along with the normal lubricants will overall help in maintaining the homeostasis better. So choose your lubricants which also contain osmoprotectants. And a special mention about another thing called ectoin. So again, in Juice 3, they have made a lot of emphasis on ectoin molecule. Now, ectoin is something which is a very good anti-inflammatory. It acts as an antioxidant. Not only this, it also maintains the tight junctions between the epithelial cells very well. So we do see that in case of dry eyes, the surface gets affected. There is a lot of erosion and the corneal epithelial cells breakage. So the integrity between the epithelial cells is very well maintained by ectoin, and even it maintains the lipid and the mucin layer quite well. Those tear drops containing this ectoin as osmoprotectant and as well as an antioxidant and inflammatory will be beneficial in a lot of patients. And this is just how osmoprotectants are going to help in reducing inflammation. This just shows that some studies, basically we see that the brighter green is indicating that once the osmolarity goes higher, these MMP expression goes higher, meaning MMP is matrix metalloproteinases. They cause, basically these are inflammatory markers. So because of these higher osmolarity, higher inflammatory markers are seen. The moment we add L-carnitine and erythritol, we see that on the right side, that the MMP expression has reduced indicating that the inflammation comes down. So addition of these is highly beneficial. So lastly, are we treating the inflammation? Now, when we talk about treating inflammation overall, yes, we have given the lubricants, we have given orthoprotectants, but also there is inflammation where we see a lot of patients looking at the eye, it's highly inflamed. We all know that there are multiple options. Commonly, we start with the corticosteroids starting with the low-dose corticosteroids. Then we also have the cyclosporin, which we commonly use. And there can also be usage of tetracycline macrolides. So oral tetracycline like doxycycline, particularly useful in cases of the MGD cases. And of course, addition of omega fatty acids. And in very severe dry eye, we also use autologous serum, which reduces the overall ocular surface inflammation. And also special mention about which molecule which we have got recently in India, which is the liftigras 5%. And also there are certain tablets which contain macuberry, bilberry extracts. These also work very well as anti-inflammatory and antioxidants. And of course, the normal and artificial tears, which we already discussed. And also in severe cases, again, platelet-rich plasma. And also punctal occlusion, just to mention here, in cases of severe dry eye, in cases of an acute inflammation, normally we do not go with punctal occlusion because when there is inflammation, we also know that the quality of tears will be bad and we do not want that kind of tears to be retained in the eye. So once we basically control the inflammation used, we can lastly go in for punctal occlusion, though it is not specifically an anti-inflammatory therapy. Just one mention about cyclosporin. Now, the moment we talk about cyclosporin and liftigrast, so the number of questions that come to us is like, when do we start this and how long do we give cyclosporin? And now that liftigrast has come, do we go with cyclosporin or with liftigrast, and multiple questions like that. Now, just for that, we need to also understand how cyclosporin works and how liftigrast works and who is the one who would be benefited. Now, when we talk about cyclosporin, it is something which acts inside the cell. It acts on what is called calcium calmodulin complex, and it will inhibit the activation of the T cells, or whatever is already activated, it suppresses the action of the T cells. But liftigrast, on the other hand, has a completely different action, which acts on something called LFA-ICAM. Basically, LFA is something called leukocyte function antigen. ICAM is intercellular adhesion molecule. So there is an interaction that happens between the two for any inflammatory mediator to be released. So this acts on LFA-ICAM. So the interaction doesn't happen, and thereby the inflammation or inflammatory mediators are not released. So cyclosporin works on a different pathway and liftigrast works on a different pathway. So thus, can both be used together? Yes, it can be used together as well because the pathway of action is completely different. Again, which patient is going to be benefited and how long, it differs patient to patient. Now, one thing to mention about any of these cyclosporin or liftigrast is that this is something which does not work in just about, like, say, 2 to 3 weeks. Though they say the cyclosporin usually takes about 4 to 6 weeks for the action to start. And liftigrast, on the other hand, the action starts by about 2 weeks. So when we're looking at a faster onset of action, usually liftigrast is something that we would go for. And in case of chronic patients, and then there is no acute inflammatory condition, in such cases, we have enough time, then we can go in for, again, cyclosporin. Also, there are newer molecules of cyclosporin which say that the action starts by 2 weeks. Yes, it does. Around 2 to 3 weeks, it might start. But again, cyclosporin usually has a longer duration of action, or rather the onset of action, compared to liftigrast. And second thing is in terms of how long do we use. So we don't generally use any of these for just about 2-3 weeks or a month. We know that the action itself takes about that much time, and we need to continue for a minimum of about 3 to 6 months if we have to see the proper results in our patients. So it's very important to advise the patients and tell that it needs a longer course. Another thing is in terms of the overall comfort. So we know that cyclosporin does cause a lot of burning sensation in a lot of people. However, liftigrast is something which is much better tolerated compared to cyclosporin. So liftigrast can be a good first choice in a lot of severe dry eye cases. And so we talked about we talked about the clear film, etc. And as I also mentioned, you have to look at the eyelid anomalies, treat them, treat blepharitis, treat meibomitis, lid hygiene extremely important. Specific mention here, we also do have like lid wipes which contain tea tree oil. Tea tree oil is excellent anti-inflammatory, and this helps in reducing the inflammatory load in the lid margin, and instead of sometimes using just a normal sterile saline wipes, we can also go in for tea tree wipes in MGD cases as well as blepharitis cases. And at home, important to do the lid massage, warm compress, and the right technique to be told to the patients, because a lot of times they just press here somewhere and it is just not working out. So important to educate the patients how to do a proper lid hygiene, and also in cases of lack of time must identify them and lid taping, etc. at night. And of course, we always have the lippy flu and other things which we already spoke about. Lastly, the ocular surface abnormalities, treat them, especially I spoke about conjunctivochalasis, do not ignore, and needs to be treated, not just with the lubricants, and with the surgical intervention will be required in these cases. And last but not the least, yes, not just treating the tears in terms of giving the lubricants, not just about treating the eyelids and not about treating only the ocular surface. It's important to tell the patient that you need to undergo certain lifestyle modifications and environmental modifications, which play an important role, like the way they use a digital screen, because of course everybody are exposed to digital screen now. It's not that they should stop, but how do they use it and how often do they take breaks? That needs to be educated to the patient. And blink often, follow 2020 rule, and humidity control in certain cases where there is very dry and less humidity, humidifiers can be used. And of course, it's important to emphasize on the diet as well as sleep. And again, cosmetics. A lot of people also ignore this because there are a lot of cosmetics out there in the market now which are not of a very good quality. So because of this, it causes a lot of discomfort, allergies, and blocks the meibomian glands, etc. So using the right kind of cosmetics, and also important to tell them to remove the cosmetics before sleeping so that it doesn't sediment over there and block the meibomian glands. And also the right way of using contact lenses, not to overuse contact lenses, also needs to be educated along with just treating the patients with medications. This is how we go a stepwise approach. So if I have to summarize the whole thing, now that we know that there are so many medications, there are so many oral formulations, there are some anti-inflammatory therapy, there are some devices. So how do I go about step by step? So the first thing is identify what exactly is the cause and treat the underlying cause, which takes care of most of the things. Second, start with the basic lubricants. Now that we know how to assess the lipid layer, the aqueous and the mucin layer, so we know what kind of lubricant works better for which kind of dry eye. So start with a basic lubricant. Then next, you can add in oral formulations like anti-inflammatory doxycycline or berry extract tablets, which also act very good inflammatory agents. And also emphasize on warm compress lid hygiene. And in cases of inflammation, we go in for, start with the low dose steroids always and step up if not responding. And also we can go in for a cyclosporin, as I mentioned, how to use and how long to use is something that we need to be clear. And again, Luftigrast, excellent molecule out in the market, which works very well for severe dry eyes. And again, adds modifications. So this is the summary of it. Just wanted to show one case wherein this was a case of basically a patient who came with, who had acute myeloid leukemia, and he underwent a bone marrow transplantation for that. And following the bone marrow transplant, he developed a chronic graft versus host reaction. And because of which there were multiple systemic manifestations like dermatological manifestation, etc. But very important, typical was the eye manifestation. He was extremely uncomfortable. He was in a very high position, had to work on multiple things on computer, and had persistent redness, dryness, foreign body sensation, the typical dry eye symptoms. And when we looked at the ocular examination, where we can see his entire cornea had diffuse punctate erosions, both the eyes and conjunctival staining, and he was just not able to keep his eye open even for like a couple of seconds comfortably. And he had used most of the medications. Of course, we did the diagnostic test and we found Schirmer's was just 1, TBOT was only 4, diffuse cornea conjunctival staining was seen. And we also did investigations where we saw NIBOT was lesser, lipid layer. Typically, we saw that because of the graft versus host reaction, the meibomian glands function was lost, and there was loss of meibomian glands architecture, and lipid layer was affected because of that. Tear meniscus height was lesser, etc. And he had started on all the medications, starting with the steroids, lubricants of all types, etc. And of course, cyclosporin he was using for a very long time, for even more than 2 years. So, of course, with cyclosporin, he was much comfortable, but still his symptoms persisted. And however, with the addition of liftigrast, I could see very drastic improvement in this patient. And literally after that, we can see this is a cornea where the completely erosions are gone and the patient was quite comfortable. That is one case where we know that step by step what can be added. And in my practice, I feel that liftigrast is something which helps very well for these kind of severe cases. And now that it's available to all of us, it's much better. And again, all his parameters improved after that. Then last case, finally, this is a Stevens-Johnson syndrome sequelae, and he also had severe erosions of cornea. Anyway, we know that the mild cases, we have the basic lubricants. We have these severe cases where it becomes a little challenging in terms of what to use, how much, how long to use. And this is again a case of severe dry eye, but post-treatment, I need to get the pictures. I do not have that. Again, to start with the steroids, use good lubricants, which like sodium hyaluronate with osmoprotectants will be better, because in these kind of cases, definitely the osmolarity is something which is affected. And also the thicker formulations in the form of gel, like a vitamin A gel will work better for the epithelium, and also pantothenic acid, those kind of gel helps better. And again, cyclosporin, when you're starting, keep a minimum window period of 3 to 6 months. That is how long it takes for these kind of cases. And yes, liftigrast is an excellent alternative, or rather option to use now, and well tolerated than cyclosporin as well. And also we have oral formulations in the form of macuberry extract, or even bilberry extract, and omega fatty acids formulations. And with the basic thing, also give an stimulation with the Lipiflor IPL, which will stimulate the persisting meibomian glands to function better. And in this case, of course, if it is a final thing, SJ sequelae, if it is very severe, we go in for mucous membrane grafting, but that's a final thing. But these are the common things that we can commonly use in our practice. And finally, I would like to end my presentation here by emphasizing on the fact that it's important for us to understand what is the cause of the dry eye, and second, identify and treat the cause, and along with that, what kind of lubricant which patient would do better, and go in a stepwise manner, and also educate the patient that this is a disease which does not get cured probably in just 1 or 2 days, and patience is required, and longer duration of the right kind of medications is something which definitely benefit the patients in the long run. I end my talk here, and I thank you all for your patient listening.
Yeah, thank you, Dr. Sanjana, for such a wonderful talk. It was very, very elaborate. Threw a significant light on the stepwise approach, because most of the time when we have patients coming to OPD, we do a Schirmer and then directly give them any over-the-counter lubricants which is there. So it's very important to have a stepwise identification for the patient, what type of dry eye. So you spoke very elaborately on that. So let me just take few questions that have come from participants. The first question is by Dr. Tina. Does liftigrast cause corneal melting in autoimmune related rheumatoid arthritis or Stevens Johnson SLE patient, and its efficacy in computer vision syndrome?
So liftigrast, no, it does not cause corneal melting in autoimmune related conditions. In fact, it is an indication to be used in especially these rheumatoid and autoimmune SJS and SLE kind of patients who do really well, because the basic pathology there is that there is autoimmune and there is an inflammation which is causing the entire ocular surface damage. And as I mentioned, the liftigrast works very well in controlling that inflammatory markers, and thereby will be, in fact, the first choice to be used in these kind of patients. And when we talk about computer vision syndrome, see, most of the computer vision syndrome will fall into the category of mild to moderate dry eye. So we generally don't start with liftigrast for these kind of patients. we would always have other options like the basic lubricants and oral formulations, and even in terms of, intense pulse light, these kind of treatments works better for them. However, liftigrast, though many of the articles and other things says that patients with more symptoms than signs, it works better. But anyway, in my practice, what I have seen is patients who have more of these signs, like diffuse erosions of corneal conjunctiva, they do very well with liftigrast rather than just the vague symptoms. However, we need to use for more patients and see. But for computer vision syndrome patients, that will not be the first choice of treatment in terms of liftigrast. Yeah.
Yeah, one more thing I would like to say is earlier liftigrast was available as 12,000. Now it is available for 2,030 unims. Plus, they have divided into tens. So, if you are very scared and using for patients, also you can just ask them to buy 10 unims and first try, because the side effects always come before the effects. So that is why, especially patients with arthritis or Steven Johnson, they have tried a lot of dry eye medication, and it's very important to know the compatibility also. So always tell them to buy the 10 unims, put it on the, try it on the patient, the compatible, then over a period of time, definitely the results are going to happen in them.
Yes,
So the
absolutely.
next question is the safety profile of cyclosporin in pediatric population, as well as the role of tacrolimus in dry eye.
So the safety profile of cyclosporin, though usually the article says that it has to be used in patients more than 15 years only, but off-label we have been using for younger kids also. And in fact, the chances of seeing the severe dry eye in pediatric population is quite less. We do see in terms of more of allergies, where they have like chronic allergies, and because of which, of course, the ocular surface is affected. So in chronic allergies, along with dry eyes, of course, cyclosporin can be used, though it is an off-label to be used less than 15 years, but can be safely used. There is no problem. And tacrolimus role, again, tacrolimus is something which we would commonly use in cases of these kind of severe allergy patients, rather than these kind of severe dry eye patients. Again, it causes quite a bit of burning sensation. So generally, normally for dry eye, this is not something which we commonly use. But for chronic allergies associated with dry eye, yes, it works well.
Yeah, very rightly said, Sanjana. Most of the time in children, it is the VKC inducing dryness. So VKC, we know most of the time tacrolimus is a drug of choice. And if needed, if there's a lot of cornea staining, we end up using cyclosporin. So the next question is post-cataract dry eyes, how to manage, and pre-operatively, what do we start?
So pre-operatively, again, at least we need to do a basic dry eye assessment for even the cataract patients, because many a times after the surgery they start complaining, but if it was being identified before, it's always much better. So just a simple dry eye assessment, at least doing a Shermer's and a TBUT will tell us a lot of information, because a lot of them are older patients, and we do have that, the tear film breakup time. Just by doing a simple TBUT, it tells us a lot about how exactly is the ocular surface. So just by doing a TBUT, we understand so much. And if already there is compromise this thing, we can start them on the basic lubricant. In terms of patients, like say, there are a lot of older patients who do have arthritis and other systemic conditions, maybe thyroid, other conditions, etc. And if we have documented that, yes, it has been chronic and severe, it is also worthwhile to start cyclosporin for these patients. They do very well. Starting with basic lubricants and addition of cyclosporin pre-operatively, and even post-operatively, we anyway follow with the normal basic lubricants itself. And in these kind of cases, addition of cyclosporin also helps.
The next question is to the audience also, specifically which are the institutions of Agarwals that do have dry eye evaluation machine, and is it really important that we should invest in a dry eye evaluation machine, or the invasive technique like Shermer's or T-Butt is enough? So even from the audience, whoever has a dry eye evaluation machine could please tell us which center it is.
So, yes, when we talk about a dry evaluation machine, so normally it is giving us basically the lipid layer, and also it is telling us about the tear meniscus height, and it is talking about the NITBUT. These are the most common things. In fact, if we look at that, I would say it is really not required that every center should be investing in this, because even the basic test, like the Shermer and the invasive TBUT, gives us equally good information about that. And tear meniscus height, anyway, we'll be able to see in the slit lamp also. And investigation of this extra additional, this thing may not be a necessity in every center. However, in terms of the treatment, I would say, not evaluation is one thing, the treatment is another one. So in the treatment, when we are run out of options, like sometimes just the lubricating drops or just the oral formulation or just the warm compress at home not working, In those patients, I have seen definitely the intense pulse light therapy. What I use is intense pulse light here. I have not used much of lippy flow, but the intense pulse light therapy and of course lippy flow also, they help much better rather than investing in just an investigation. Having in specific centers this additional treatment would be beneficial rather than the only investigation part. But even the simple investigation at the OPD will give a lot of information, equally good
Yeah.
information.
Coming to lipid flow and intense pulse site therapy, is it a one-time treatment or is it to be done frequently? I'm sure most of them will be curious to know.
These are usually not only one time. Again, it depends upon the severity. If it is just a mild, let's say in cases of mild NGDs and also in certain mild computer vision syndrome patients, even one sitting gives a lot of comfort to the patients. And also in cases of mild NGD, the lippy flow, which squeezes and presses out the meibomian glands, one sitting helps. But we always tell the patients it is recommendable to go for 2 to 3 sittings. Why? Because once you do a sitting, it has to be sustained for a longer duration. So you need to step it up with the second sitting, and the third sitting is usually optional. So, but first and second sitting is always recommended.
Okay. The next question is, in your graft versus host case, why wasn't punctal plug or punctal cautery tried after checking for reflex? Because that's a root cause for inflammation. So was punctal cautery tried for the patient along with the other medication?
Basically, no. So in this case, there was a lot of inflammation. The patient had severe redness and there was a lot of inflammation on the ocular surface. So in those cases, the first important thing, we would want to control the inflammation even before we block the punctum, because the tear secretion or tear secreted already and which is persisting there is something of not a good quality. And we are allowing that same bad quality or the one which tears, which have more of inflammatory markers, to remain on the ocular surface, which causes sometimes more damage. So that will not be the first cause. Once we completely resolve the inflammation and the eye is much better, then to retain the good quality tears which is being produced, we can go in for a punctal occlusion, but that will not be the first case because of the severe inflammatory condition which was persisting. That is why liftigrafts and cyclosporin and other things were used to basically control the inflammation first.
Okay. There's another question as to how do we source the lissamine green stain? Is it available easily?
Yeah, so lissamine green is available. It is available easily, but as I said, commonly we don't use it in our practice. In fact, even the fluorescein itself we can identify the conjunctival staining even with fluorescein, so that should be good enough. Why we commonly don't go for it is because it causes more stinging and irritation, and that's the reason we don't use it. But yes, if required, it can easily be got it in the hospital. Yeah.
Okay. The next question is for somebody who's ANA and rheumatoid factor normal, patients presenting with severe dry eye with filamentary keratitis, how do we go ahead? Any other evaluation to be done? Any other different workup to be done for such patients?
See, usually the filamentary keratitis, specifically if you have to look at, we have something called mucomix injection that we get. So these are mucolytics, that is N-acetylcysteine. They work very well for filaments. Of course, lubricants we will be using, but along with the lubricants, if we add this N-acetylcysteine, this will help in dissolving or rather curing these filaments much better. Filamentary keratitis, that is a must to be used. And should we go ahead and do any more workup or start on cyclosporin or liftigrast? Yes, if we have to look at filamentary keratitis, cyclosporin works better than liftigrast in these cases. So lubricants along with N-acetylcysteine drops and cyclosporin and gel works very well for filamentary keratitis.
Okay. There's another question. Now, one of the doctors, they would like to know how exactly do we do a warm compression lid massage to the patient? They're requesting you to demonstrate it. So when we explain do a lid massage, some people just blow it on their hand and just keep it like this. So there are different ways. So how do you explain what is the exact way, sterile cloth, those procedure of warm compression?
Yeah. So when we talk about the heat, we have mainly the dry heat and the wet heat. I would generally recommend to go in for dry heat because many a times people do use like kerchief which is dipped in water, hot water, and keep it on the eye. Yes, that can also be done. But sometimes we do feel that it's a little more cumbersome because sometimes the water dripping and all, they may not be very comfortable. The best way is also like use a kerchief, ask them to eye on it and make it hot, and then keep it on the eye for about like 5 minutes. And after that, they need to very close to the lid margin, it has to be done in this manner. So from the nasal part to the temporal part, sometimes they do somewhere here or they do here and they just touch and they don't press properly. So you have to tell them the amount of pressure. We can just show them the right amount of pressure that needs to be applied. Just do a motion from this side to this side a couple of times for about, like, say, 10 to 15 times. And after that, they can also use like wet wipes, because some of the gland secretion would have been kind of getting accumulated in the lid margin. Take a tea tree oil wipe or something and clean the lid margin. So this completes the whole cycle of lid hygiene.
I'm sure that doubt has been cleared very well. Now, the next one is, do you recommend eye care kit Eyelysis, which is available in the market for warm compression in children?
Children, not really, because first of all, this is something which needs to be plugged to an electric source. Although now recently we have got it wherein you can plug it to a mobile phone also, or otherwise you have to plug it to an electric source. So these kind of things usually we would not recommend to go for children, and children usually don't really come up with that kind of dry eye issue. This is more for, like, the subtle dryness where they want a soothing effect at the end of the day. So kind of computer users and all, this works well. But otherwise, it is not something which we normally give for children.
So instead of this, probably we can use the eye masks recently, which are available, the cold and warm eye mask. If you just dip it in hot water, the patient can literally place it on the eyes for 5 to 10 minutes. They don't have to use the conventional kerchief and all those things. So it'll help for the IT patients, fancier patients actually. So next question is anti-inflammatory doxycycline dosage and McBride. How long do we wait for the response?
Yeah, so doxycycline, this is something usually in cases of like severe MGD cases, we generally recommend in terms of 100 mg BD, we give it for about 2 to 3 weeks. Again, the tolerance is a little bit of an issue in most of the patients. Again, gastritis and other problems. So we need to give proper antacids and also tell them that this tablet might cause a little bit of discomfort. That is one. And second thing, Macubrite or Macuberry, normally the dosage is like, basically it comes as 30 milligram tablet. So we need to give 30 milligram twice a day for about a month, and then followed by 30 milligram once a day for the next 2 months. So usually they recommend a 3-month course, wherein first month will be 60 mg and the next 2 months will be 30-30. Yeah.
Okay. Then and the next question is, child with a bone marrow transplantation was developed severe adenoviral membranous conjunctivitis. What do we use? Already on FML and Trehaloob, so can we add cyclosporin?
Yeah, definitely. Cyclosporin can be definitely added. 4 years of age, yes, off label again, but it can be added. And in fact, we can also add tacrolimus. In fact, tacrolimus, again, we have lower strength and higher strength. But child is not able to tolerate the higher strength because of a lot of stinging and all. We can start with tacrolimus lower strength, and that should also be good enough along with cyclosporin.
Yeah. And in cyclosporin, no financial interest, but Sequa really has very good penetration and results because of the micellar component. So the patients are very compatible when it comes to the regular 0.05% to 0.09%. So I normally prefer post-LASIK, post-cataract, all these patients. The unims of Sequa actually work really well in these patients. So next, antibiotic ointments for lid hygiene, probably for blepharokeratoconjunctivitis patients or severe MGD. Which antibiotic? We have the azithromycin antibiotic, Forquin antibiotic. Which is better for the patients?
Usually, yes, for the lid hygiene patients, azithromycin is something that will be the first choice.
Yeah. Then again, we have Dr. Uma ma'am who was telling that in Tambaram there is a dry eye workup machine. So that is one thing. Second is, could you please explain more about the intense pulse light therapy? Like what exactly happens in this, and what should we tell the patient to be having an idea before he goes in for it?
Yeah. So intense pulse light therapy is very, very comfortable to the patient. In fact, we tell them like it's more like you're going for an eye spa kind of a treatment. First of all, what we do here is that we put the gel, which is a cold gel over here, and then on top of it, we are going to give it is a xenon light. So we give 5 shots, 1, 2, 3, 4, and 5. So what it basically does is, it is going to stimulate, it's a parasympathetic pathway. We have a parasympathetic nerve pathway which goes to the meibomian glands and which goes to the lacrimal glands. It basically stimulates those parasympathetic nerves which are basically supplying the meibomian and also the lacrimal glands. So once it is stimulated, it is considered that the lacrimal gland functioning is supposed to get better. The secretion of the tears is supposed to get better. That is one. Second, it also, because there is heat production, it kind of melts the meibomian glands, and then if you do the massage, the secretions will come out better. So this way, it helps in releasing the meibomian gland blockages. It also stimulates the meibomian glands and lacrimal glands to work better. And it's very comfortable to the patient. There is no downtime. There is no extra care that they need to take after the surgery. Nothing. I mean, sorry, after the treatment, nothing of that sort. It's just a walk-in, walk-out kind of a procedure. And 2 to 3 sittings is what we generally recommend.
Okay, thank you. So we'll take up the last question. In dense subepithelial keratitis post-viral infection, how do we treat it or how do we prevent it?
Preventive treatment for SPK psoriasis. So again, these kind of patients, initially, we will have to start them with the steroids. After that, cyclosporin works really well in these kind of patients. But again, if we have to prevent the recurrences, it is very, very important to put them on long duration. Because again, if we give it for 1 month and stop, it is not going to work at all. It is something minimum, it has to be given for 3 months. And you know that viral infections are something which can always keep getting reactivated multiple times at any point. Again, giving it for a duration of, let's say, 6 months, and then you can kind of stop it in between and see if there is any recurrence or not. If not, continue further. And along with that, even the tacrolimus, if it is like recurrent multiple times and is severe, we can also add tacrolimus, low dose. That also helps. Basically, we are suppressing the immune response of the viral secretions. Yeah.
Yeah, so one of the very important factor is steroids immediately brings down the viral conjunctivitis, but it's very important to tell the patient that please use the medication for 2 to 3 weeks. It is these patients who stop after 1 week because they don't have any symptoms who come back later to us with SPKs. So telling the patient to taper the steroids and use it at least for compulsory 3 weeks with or without symptoms is definitely going to prevent SPK from even happening. And once it happens, definitely, as Dr. Sanjana said, long-term treatment is very important to bring down the immunosuppression. Yeah, the last question by Dr. Preethi ma'am. Should we massage along the gland up to down from the punctum or along the margin?
One thing is, yes, we can massage up to down also, but even if we massage up to down, the lid margin massage is also very, very important, because sometimes, from up to down, it can get accumulated at the lid margin. That's where the capping happens. And if we press particularly at the lid margin is when the secretions actually start coming out. We can also do from down to up and up to down, and again from nasal to temporal side, so that from top to bottom it has been squeezed out and then it is squeezed outside as well. So doing the lid margin massage is also very important.
Yeah, to conclude, if you can just categorize for evaporative, aqueous and mixed dry eye, which are the common component medications that can be used? That was one of the questions, specific dry eye combinations which can be used for aqueous, evaporative and mixed dry eye.
Yeah, so usually for the aqueous deficient dry eye in the mild cases, we can even use the CMC 1%. That also works better. In moderate severe cases, again, sodium hyalinate along with osmoprotectants, they do well. In cases of lipid deficient dry eye, you can commonly go in for, again, even PEG also helps. PEG, along with that, some of the medications do contain castor oil and mineral oils or even lipid globules. So that can be beneficial. And for mucin layer, usually they recommend polyethylene glycol, propylene glycol ones. And of course, cyclosporin also works very well for the aqueous layer and the mucin layer.
Thank you very much. That was really extensive discussion on dry eye. Thank you for all the participants for taking up, making time to attend this discussion. Thank you, Preethi ma'am, for entrusting myself and Dr. Sanjana ma'am for this very important dry eye topic, which is a bread and butter before we treat any kind of a disease in the eye. Could be cataract, could be glaucoma, could be cornea, any kind of a disease. So thank you very much for everybody attending this session.
Yeah,
Thank you,
Dr. Sanjana. Thank you, Preethi ma'am. Thank you, Clinical Board. And thank you, everyone, for a great discussion.